If you've ever watched combat sports, you know, MMA, judo, Brazilian jiu-jitsu, you definitely see the grind.
Oh yeah, the constant impacts, the twisting, grappling.
Yeah.
It's just brutal on the neck and traps.
Absolutely. And when that really persistent, deep neck pain kicks in, the kind from those stubborn muscle knots, well, what actually works best to get those elite athletes back in action, like, fast?
That really is the key question, isn't it?
Yeah.
We know traditional physio helps, but for high-performance athletes, we're always looking for that edge,
Yeah.
faster recovery, but also more sustained recovery.
Right.
And the big debate we're tackling today is whether adding something a bit more invasive, like dry needling, to the standard stuff actually gives measurably better, longer-lasting results.
And that's exactly what we're doing today. Diving deep into a really solid study, a randomized controlled trial that compares these two approaches head-to-head.
Yeah.
We want to see if there's real physiological proof that combining manual therapy with dry needling DATDN is genuinely superior for these athletes who need that neck stability and, well, zero pain.
And for anyone wanting to follow the specifics, the study we're digging into is titled Combination of Manual Therapy and Dry Needling Effectively Improves Acute Neck Pain and Muscular Tone and Stiffness in Combat Sports Athletes, a randomized controlled study.
Okay.
It's authored by Adrian Kużdzał and a team of colleagues, published in the Journal of Sports Science and Medicine, just this year, 2024.
Great. Okay, let's unpack this, starting with the basics. Why is neck pain such a huge deal specifically for combat athletes?
Well, it really comes down to chronic overload. Think about it. The neck and upper traps aren't just holding the head up.
Right.
They're constantly absorbing force, often unevenly, during throws, clinches, groundwork, taking hits. And this pretty quickly leads to what we call myofascial trigger points, or MTRP.
Okay, trigger points. We hear muscle knots thrown around a lot, but MTRPs are. They're a bit different physiologically, aren't they? Can you break that down for us?
Yeah, definitely. Imagine like a tiny microscopic cramp within the muscle fiber itself. An MTRP is this hypersensitive tight band of muscle that you can often actually feel.
Okay.
And it just won't relax properly. But the key thing is, it doesn't just cause pain right there. It causes referred pain, pain that pops up somewhere else.
Ah. Yeah.
Plus, it restricts blood flow locally and messes with how the muscle actually functions, makes it weaker, stiffer. For a combat athlete, that's stiffness, limited movement, less power. It's disaster for performance.
Yeah, absolutely catastrophic. So the MTRP is the bad guy here. The study looked at two ways to tackle it. First up, manual therapy, MT.
Right. In this particular study, the MT focused mainly on something called ischemic compression, or IC.
I see.
Yeah, it's pretty straightforward, non-invasive. The therapist uses their hands, usually thumbs or fingers, to apply steady pressure directly onto that trigger point.
Okay.
They hold it for about, say, 90 seconds. The theory is this pressure temporarily cuts off some blood flow. That's the ischemic part. And when you release it, exactly, you get a rebound effect, a rush of fresh oxygenated blood into the area, which hopefully helps that knot release and eases the pain.
Makes sense. And then the other approach, bringing in the needles. Dry needling, DN.
Yep. Now, DN is different because you're actually inserting a very fine needle, like an acupuncture needle, directly into that trigger point.
Okay, so physical penetration.
Right. There's no medicine injected, hence dry. The goal is mechanical and neurological stimulation right at the source of the problem.
Stimulating the knot itself.
Exactly. Targeting the MTRP and the surrounding connective tissue. You're often looking for what's called a local twitch response, or LTR.
The twitch.
Yeah, a little involuntary muscle jump. It's seen as a sign you've hit the right spot and initiated a release. So the whole point of this study was really to see if combining these two, the needling and the manual therapy, MTDN was worth the extra step, the slight discomfort of the needle, compared to just doing the manual therapy alone.
Because, as the paper points out, the evidence on whether that combo really gives consistently better results than MT alone? Well, it's been a bit mixed, hasn't it? Especially for these top-tier athletes.
Precisely. There was this gap in clarity. So to address that, the researchers used the gold standard method,
Yeah.
a randomized controlled trial.
Right.
Specifically, single-blind, parallel design with repeated measurements.
Okay.
Very robust setup.
And the participants weren't just average gym goers. These were serious competitors.
That's a key point. 30 highly trained, national-level combat athletes, mostly men, average age around 26.
Okay.
And they all had one-sided neck pain going on for over a month, with confirmed MTRPs in their upper trap muscle. They were then randomly split, 15 in each group.
Now, the methodology here had a really smart detail to handle bias, right? Tell us about the two groups and how they managed the blinding.
Yeah, this was crucial. You had the intervention group, the MTDN group. They got the full works. Real dry needling, looking for that twitch response, followed by the manual therapy, the ischemic compression, and some rubbing.
Okay, the real deal.
Then you had the control group, CG. They got the manual therapy too, but instead of real needling, they got the quasi-needle.
The quasi-needle. Sounds intriguing. What is that?
It's pretty clever, actually. It's a device designed to mimic the feeling of a needle prick without actually breaking the skin. It might have a spring or blunt tip that gives that sharp pressure sensation, but the needle part retracts, so the athlete feels something like an insertion.
But nothing actually goes in.
Exactly. And since they were lying face down, they couldn't see what was being used. This sham needling is vital.
Yeah, because it helps ensure any better results in the MTDN group are actually from the needling itself, not just because the athletes thought they were getting a more powerful treatment, the placebo effect.
Precisely. It isolates the physiological effect of the needle penetrating the MTRP. Really well designed.
Okay, so both groups got 3 sessions spaced 3 days apart. And they weren't just asking, how do you feel? They measured things objectively.
Absolutely. Hard data. They took measurements at 4 key times. Baseline, before anything, 5 minutes after the first session, 5 minutes after the third session, and then, critically, a follow-up check 72 hours after that last session.
The 72-hour mark seems important.
Very. It shows if the effects last. They measured muscle tone, let's call it M-tone, to avoid confusion with manual therapy MT and muscle stiffness, MS, using a device called a myotonometer.
Okay.
They measured pain sensitivity with an algesiometer, looking at the pressure pain threshold, PPT. Higher PPT means less sensitive to pain.
Got it.
And they also checked range of motion, ROM in the neck, and maximal isometric strength.
Fmax.
All right, the moment of truth. Let's get to the results. Did adding the needle actually make a difference? Was it worth it?
The short answer, yes, unequivocally. The MTDN group, the one getting the real needles plus manual therapy, showed significantly better improvements compared to the manual therapy plus sham needle group.
Okay, in what areas specifically? Particularly in M-tone, muscle stiffness, and the pressure pain threshold. Especially clear after the third session, and even more so at that 72-hour follow-up.
Let's zoom in on stiffness, MS. That's a huge limiter for athletes, that feeling of being locked up.
Huge difference there. By the 72-hour mark, the control group still had significantly higher stiffness than the MTDN group.
So the MTDN group felt looser, longer.
Much looser. And the researchers calculated the effect size a way to measure the magnitude of the difference. For stiffness at 72 hours, it was classified as very large. D equals 2.45.
Wow. So statistically speaking, that's not just a tiny edge. That's a substantial, meaningful improvement.
Exactly. It's the kind of difference an athlete feels. It can be the difference between feeling, say, 70% ready versus 95% ready to train or compete. The benefits of the combined approach for reducing stiffness were really sustained.
That lasting effect, that's really interesting. It suggests the needle is doing something more profound than just temporary relief from the compression.
That's the thinking. It likely comes back to that local twitch response, the LTR we mentioned.
Right, the muscle jumping.
When the needle hits the MTRP just right and triggers that LTR, it's thought to cause a kind of neurological reset. It stimulates the muscle fibers, and importantly, the muscle spindle, the sensor that detects stretch.
Okay.
The LTR seems to disrupt the faulty signaling that's keeping that part of the muscle constantly tight, reducing that hyperexcitability at the source.
So manual therapy might address the physical knot, but the needling gets at the underlying neurological reason for the tightness.
That's a good way to put it. And that could explain why the MTDN group had that sustained reduction in stiffness even 3 days later, whereas the control group stiffness might have crept back up more.
Makes sense. What about pain relief? The pressure pain threshold, PPT.
Similar story there, especially regarding the lasting effect. At the 72-hour follow-up, the MTDN group had a significantly higher PPT.
Meaning they could tolerate more pressure before feeling pain.
Correct. Again, a large effect size, D equals 1.80, so less pain sensitivity, and that benefit held up over time for the needling group compared to the control group.
Okay, but you mentioned something about the timing. The recovery wasn't instantaneous across the board, right?
That's a really crucial clinical point. While M-tone, the muscle's resting tension, improved pretty quickly, the really significant improvements in stiffness and pain threshold actually continued to develop right up to that 72-hour mark after the last treatment.
So the benefits kept accumulating even after they stopped the sessions.
Exactly. It wasn't like, boom, treatment done, maximum benefit achieved. It tells us that the tissue needs time to adapt, and the full pain-modulating effects take a few days to really set in after the combined therapy.
So the MTDN isn't just a quick fix. It seems to kickstart a recovery process that unfolds over days.
That's a great way to think about it. It's a catalyst. The needling seems to hit the neurological reset and deep release, and the manual therapy then complements that by improving circulation and addressing maybe more superficial tightness. They work together synergistically.
Okay, that paints a pretty clear picture of benefit for pain and stiffness, but science is rarely simple. What didn't change significantly between the groups? Where did MTDN not show superiority?
This is just as important for practitioners and athletes to understand. Despite those really positive results for muscle quality and pain, there were no significant differences found between the MTDN group and the control group when it came to maximal isometric strength, FEF-max.
Okay, no strength difference.
And also, no significant difference in range of motion, ROM, specifically looking at neck side bending and rotation.
That's interesting. You'd intuitively think if a muscle feels less stiff and hurts less, it should be stronger and move more freely. Why wouldn't that be the case here?
That's the common assumption, but the data suggests it's more complex. The researchers propose some good reasons. Maximal strength, FEF-max, depends a lot on the brain's ability to recruit motor units effectively, that neural drive. Dry needling is great at reducing the negative signaling from a trigger point, the hypertonicity, but it doesn't necessarily train or enhance the positive neural pathways needed for generating peak force.
So you get rid of the brake, the knot, but you haven't necessarily pressed the accelerator harder, neural drive for strength.
Exactly. And a similar logic applies to range of motion. While DN can definitely improve muscle flexibility by releasing MTRPs, maximum range in a joint like the neck often depends on other things too. Think about joint capsules, ligaments, maybe even the alignment of the small facet joints in the spine.
Structural limitations.
Right. Dry needling targets the muscle, myofascial tissue. It's not designed to, say, mobilize a stiff joint capsule or lengthen a ligament. So if those structures are the main things limiting how far you can turn or tilt your head, just needling the muscle won't fully solve it.
Okay, that's a critical distinction. So if your main rehab goal is purely boosting maximum strength or getting that last bit of neck rotation back, MTDN alone might not be better than just good manual therapy.
Precisely. It tells us MTDN is a powerful tool for specific things, namely improving muscle tone, reducing stiffness, and alleviating pain, especially with lasting effects. But it's not a cure-all for every single performance factor.
Right.
You'd likely need to add other specific exercises or techniques like targeted stretching or joint mobilizations if strength or ROM are the primary targets.
So pulling this all together, what are the key takeaways for, the athlete listening or the therapist planning a recovery strategy?
Well, clinically, the evidence here strongly suggests that if your main goals are rapid and sustained improvements, getting rid of that muscle hypertonicity, reducing stiffness, and providing lasting pain relief, then the combined MTDN approach should probably be prioritized.
Okay.
Especially given those superior results seen at the 72-hour follow-up for stiffness and pain tolerance. The combo seems to offer more durable benefits.
And the study gives us a clue about how much treatment is needed too.
It does. Since those significant gains in stiffness and pain were still improving after the third session, up to 72 hours later, the practical advice would be to plan for at least 3 sessions of MTDN.
Right.
This allows time for those progressive, lasting physiological adaptations to really take hold. Stopping after just 1 or 2 might mean missing out on the full potential benefit.
Okay, so the bottom line seems to be, yes, dry needling is more invasive than just manual pressure. It involves needles going into the muscle.
It does.
But at least according to this well-designed study on combat athletes, this has been a fantastic breakdown. Hopefully this deep dive gives you, our listener, a really clear understanding of this specific area in sports therapy and helps in making informed choices. If you're fascinated by the details and want to see all the numbers,
which we always encourage,
we definitely recommend you check out the full article by Kużdzał and the team. You can really dig into the methodology and the complete data sets there.
And of course, if you find these kinds of evidence-based explorations valuable, make sure you follow the channel and maybe turn on notifications. That way you won't miss our next deep dive into the latest research shaping performance and recovery.
Until next time, keep digging.